We have a phenomenal project planning inventory that my wonderful colleague Anna Morgan Barsamian created. You will get this at the end of the session. I will drop a link in the chat so you have it, and I will make sure you have it at the end of the summit as well. I will be dropping links as we go, but again, you will have a full resource list. And anything I covered today from the NARCAD website is all on there. You can always email me directly so I can tell you where to go, or we can hop on a Zoom together and I can give you a tour. So just know that up front. All right, we're going to go broad here, and Amanda's going to talk about why we do the work that we do. And many of you have seen this slide before. It's one of my favorites.
Yeah, so thanks, Bevan. I think we wanted to make sure that we covered the range of experience that might be in the room. And what I can say is that no matter what your budget, we know that there is a huge gap between what the best evidence says and what's happening in current practice. And that is really the void or the gap that we're trying to close when we're doing academic detailing. And so sometimes I feel like we're this person who's trying to hang on to both sides and really just pull it together as much as we possibly can, because no matter what budget you're working with, this is the heart and soul of academic detailing. It's trying to close the gap between actual and ideal practice.
100%. Yep. And also, how do we do that when our pockets are tight? Narissa, I see your question about operating on a lower budget in terms of fewer staff resources and less time. We'll try to weave that in. This is for the newbies. You all may not need this. Some of you may know this like with your eyes closed, but AD, just as a refresher, it's about 15 to 20-minute sessions, sometimes more, sometimes less, always one-to-one. You've got your individualized needs assessment between the detailer and the clinician to really draw that clinician out, ask them questions, understand their experiences, their current knowledge level, what their attitudes may be towards a certain, or around certain disease states and certain conditions. Featuring illustrative detailing aids. We hope that every program has the ability to create a little something that's shiny and colorful. We'll talk a little bit about that and what those detailing aids do. We'll cover that too. And again, always interactive, never a lecture. That's why we love it. The goals are always to try to close that gap Amanda was talking about. After understanding where the clinician currently is at, engaging that clinician more and more and kind of walking them towards a specific behavior change or two that you would like them to follow through on, to adopt. So again, encouraging behavior change through specific key messages. We'll show you examples of good ones. All right. So what makes AD uniquely effective? Amanda, kick us off.
Yeah. As a reminder, generally, most services consider it opt-in. So the reason why it's so easy a lot of times to develop that relationship with a clinician is that the clinician wants to be there. And it allows you that opportunity to really focus on behavior change. Some programs do have some mandatory components, but for the most part, we're talking about an opt-in service.
100%. And that's, no one likes to go to something that they have to go to. It kind of just changes the whole psychology of it. It's also customized, right? No two detailing sessions should be exactly the same. You can sort of go where that individual clinician wants to go and kind of get them back to the key messages that you need to deliver, but also making sure that the ways in which you're delivering them might be different in terms of your wording and what motivates one clinician over another.
Academic detailing is human-centered. So human-to-human communication is the heart of academic detailing. We really focus on relationships and bring evidence to clinicians in that one-to-one customized interactive way.
It's also highly adaptable. So it's something you can do on the go. If someone's walking down a hallway, you shouldn't need to have, a projector and a slide deck. It's something that, as Amanda said, is really focused on the human connection.
And we know academic detailing works. We have over 40 years of randomized trials showing that academic detailing works. And so maybe, Narissa, to start that conversation a little bit about how to tie in budget, sometimes programs or services get off the ground and funders want to see like trial quality data. And we'll talk about evaluation. Evaluation is important, but that's different from research. And so when you have a low budget, really outlining what needs to be done versus what you won't need to focus on. So I would focus more on the delivery of the service and doing some evaluation around fidelity to that delivery than really trying to prove something that's already been proved for decades. And that can be a tough conversation with funders sometimes, but that's just a start to that conversation about how do you operate on a lower budget.
All right. So let's talk a little bit about planning. Again, can't say enough. There's no one right way to do this. Each program's different. You've got different goals, needs, resources, timelines, clinical areas of focus, team members, funding, what your funder wants. I mean, assuming you have a funder, we don't think anyone in the room is doing this just for funsies. If you are, come talk to me so I can, I don't know, figure out how you live your life. But the spirit of AD should remain the same across programs. We're changing clinician behavior to improve patient health. These factors at the top in italics are very, very important. And then also sometimes they're fungible. You can have conversations at times with your funder to explain certain things, to say, hey, if you're looking for this, this is going to take me more time and resources to prove to you or to show you or to get the kind of evaluation data that you want. If you want me to show you this, then I can use the resources I would have used for your original ask to meet with more clinicians. So again, don't be afraid to try to talk to your grant project officer, your funding officer, your leadership, from whomever the funding trickles down, build a relationship early with those folks.
All right, so where to start? Most programs have some kind of directive, goals, deliverables, something that is tied to money to getting the program off the ground. And it's really important that you know what those are. And so if somebody else has gotten a little bit of money, for example, and they're coming to you and saying, okay, we got this funding and now I want you to launch an AD program, I would be sure that you understand what's in that written contract. What are you being asked to do, particularly if you're on a low budget, because that's going to dictate what steps you take next. No matter what you do, you'll need to figure out the logistics, but the order of how those things happen is going to vary across your various programs.
All right, so first things first, what do you already have? Take your inventory. As Amanda said, what's your large picture directive or goal? What's the thing that needs improving? This is going to come from your funding source and any related data that proves or shows or illustrates that gap in care. Who's with you? Do you have a team? This seems like a Captain Obvious question, but if you are going it alone, you may want to figure out, can you get anybody in maybe your department, if you're working in public health, if you're working at a university, does anyone even have 10% of time to do something as simple but time consuming as scheduling visits, as looking at data once a week, as polling data, calling data, looking up literature, whatever it is? So if you're going it alone, it's really key to see, can you find anyone to support you? This includes, do you have the ability and approval from leadership, and who knows, maybe you are leadership, which is wonderful, to get a temporary unpaid intern. Sometimes getting somebody to support you 2 hours a day, 3 days a week can make a big difference in giving you the wiggle room to do something different. And so if you have, public health grad students, undergrad students, they can really, really support you. What's your budget? Again, you want to look at what you are being given and look at everything that it is going to cost. Again, that sounds obvious. That's how you do a budget. But you want to look at, how many staff hours do I think it will take to be in the field? Am I including preparatory time, processing time of the data and collecting during those visits? And we'll talk a little bit more about that, but whatever you think it will cost, it will usually cost a little bit more. So you may want to do fewer visits, but do them, do more quality visits, but fewer, versus trying to stretch your dollar really, really thin. As Amanda mentioned, what are the deliverables? And do you have a working time frame? Sometimes we end up paired up with funders that are like, here's a big bucket of money and do the thing by December. Sometimes it's a 2-year grant and we don't exactly know what are the deliverables for the first 6 months, the second 6 months, and so on. All right. So let's practice. Choose any topic and type in the chat box. Name one thing that clinicians in your community should be doing differently to improve patient care. Anything. What's the first thing that comes to your mind? Especially if you had a magic wand, what's a gap you would close? So pop that in the chat box. You can also wave your hand or put the raise hand icon up. Carolyn, listening to their patients. Yes. Carolyn, can I unmute you and have you give me a little more context of just sort of what in particular? Is it about decision making? Is it about a specific condition they may have?
I think many times when, and I've experienced it as a patient myself, when you are in an appointment with a provider and you know they're somewhere else. They're not really there with you. They're focused on other things that they have to do, and they might even push you off. So and say, oh yeah, that's probably related to this, or especially as women, we hear a lot, oh, it's probably anxiety.
Oh,
or
yeah.
it's probably menopause, or it's probably hormones. Yeah, and so just actually listening with concern and genuine curiosity on how they can address the concern that the patient's bringing in.
I love that. And it's also treating patients as having the best data on their experience. That's wonderful. Becoming aware of the resources around them. Yes, offer meds to treat substance use disorders. Primary care docs seem reluctant to do this. Reflex testing, all HCV tests, aiming for lower blood pressures with a goal to improve patient outcomes. Comfortability with prescribing bupes, same thing as Julia. Becoming culturally aware, patient education, de-prescribing, all really great stuff here. Thanks, guys. So again, just getting used to figuring out these things need to happen. I might ask you the question, well, how do you know these things need to happen? And it's not just because people are talking about it. It's because there's a clear gap where the kind of care that needs to be provided is not being provided, or it's not being provided enough or consistently. All right.
I just want to add one just to
Yes,
respond
please.
to Nicole's. Again, through the lens of like, we have no money, low budget. Sometimes if you can just get resources in the hands of clinicians, you can like offset the fact that you don't have the money to create all this wonderful stuff. So just being aware of what's in your community and linking, being like that cultural broker that can link the clinician to the resource is sometimes a huge win when you might wish you could develop your own app or your own resource or something. Just linking people together sometimes can be a big, big win in a low budget.
I love that. And then going back to defining deliverables, sometimes again, funders will say, improve this big picture thing, but they don't actually give you concrete, sort of nitty gritty deliverables. You might say, hey, I can track the number of referrals I've made to resources in the community. So these are things where if you know what is easier to track, you can offer that as a deliverable as well. So I can't say enough, communicate with your funder. All right, so now we're on target clinician population and key messages. Let's say you know what needs to be done, but the who needs to do it. Which clinicians do you need to meet with and how will you meet with them? Amanda, over to you.
The behavior change is like the heart and soul of why you're in a visit. You're trying to encourage a clinician to make a change that will lead that person closer to ideal practice. And so it's really important to use strong action verbs here and be specific. So instead of prevent HIV, you might say prescribe HIV PrEP and discuss sexual health risks with men who have sex with men. This is incredibly important. I always challenge my team to say, if you walk into a room and a clinician says, hey, Amanda, just tell me what you want me to do, I should be able to answer that question in one sentence. And that should be the behavior change I want that clinician to make. So it's really important that you are really specific with what it is you want someone to do.
100%. And last but not least, you want to think about what your campaign materials will look like. We'll talk more about creating those a little later on. We have a lot of great resources for those. All right, over to you, Amanda.
So it's also important to think about what healthcare setting you want to be detailing in. Detailing visits will look slightly different depending on where you are. Are you targeting primary care practices, specialty clinics, hospitals, emergency departments, community health centers? Again, the spirit of academic detailing is going to be the same, but the way you put together your materials, the way you approach the visit might be slightly different depending on which clinicians you're trying to make an impact with.
Yes, so think about the kind of messaging you would have for a sort of more quiet rural mom and pop practice versus a busy ER. You really want to think about, the different ways to communicate what you need to communicate without getting thrown out. All right.
It's really important to think about the target you have for the number of visits or the number of clinicians that you're trying to reach. And here's another place where we need to be thinking a lot about the budget and staff and resources. What is the funder asking you to do? What do you have the budget to do? What's reasonable? And really making that plan upfront before you embark on delivering any kind of service.
I think one thing that at NARCAD we've seen for the past 15 years that I cannot emphasize enough is it is better to do fewer visits with multiple visits versus more visits only once. If you see somebody one time, the likelihood that they will feel a sense of accountability or connection to you and that they will follow up on their own and really stick to what you've discussed is so much lower than if you say, I'm going to come back in 3 weeks, 4 weeks, 5 weeks. If you're able to do at least one follow-up, sometimes 3 can be the magic number. It would be better to have 25 visits with 2 visits each time versus 50 one-offs. That is my take. Just based on people seeing whether or not somebody, hey, I thought Amanda was a great detailer, and in 2 days I'm going to forget about her, and I'm not worried about whether or not I have to show her that I did what we said we were going to do. And then Amanda, this piece is key as well, especially in our current world.
Yeah, absolutely. And I'll just say quickly, it seems tempting on a low budget to say we're only going to do virtual visits, but I would caution you about that because it's really a lot easier to quickly establish a relationship with somebody if you show that you're willing to go to them. And so we often try to, at the very least, get that first visit in person if possible, because you can make a connection so fast and you're showing that you really are a service. You're willing to drive to that person, if at all possible. Follow ups can easily be virtual and you can maintain that relationship really well. It's possible to do this all virtual, but it is a little bit quicker and faster. And maybe some of the folks who have a lot of experience in the room here with academic detailing can share their experiences as well. But I do find that you want to make that connection as quickly as possible, solidify that relationship so that when you are trying to encourage behavior change, people trust you.
Yes. And the other piece is we've heard from multiple programs that they be getting ghosted. Like if people set up a virtual and it's the first time, they are so likely to be blown off. But if they set up, as Amanda said, an in-person and then the follow-up is virtual, the likelihood that folks will attend that appointment is so much higher. And Nicole, we love your comment here. Sites won't, well, I don't love it, won't see you virtually. You can only get in if you go in person. Is that just because you think a policy around it, or is it more like, no? Do you want to share?
It's just their preference. I've had a few
Okay.
physicians tell me they spend all day looking at a computer. They don't want to do that for their education, and others just don't know how to use a computer. I have some older individuals that don't have an email address, but I can email their admin.
Okay. So yes, it is a comfort, a choice, a preference. Important to think about all that good stuff. All right, we're going to take a pause and see if there are questions thus far. So far, we've covered why AD works, taking your general inventory, defining goals, and selecting clinicians and environments. After this, we'll talk about evaluation. Anything so far or any reflections? As Amanda said, there are some folks in the room that may have things they want to share about how they've done things. Yeah, Charles.
Yeah, I was just thinking, I learned all about, the importance of follow-up in all the AD training I've had. But in this project I've been doing recently, I did actually schedule follow-ups with a few people, but it was actually because they wanted more, and we
Ah,
did that at a time. But I've totally forgotten the idea of just scheduling a check-in visit, to follow up. Oh, I
yeah.
have often communicated one way or another with a lot of them.
Yeah, that's awesome. And I love that that means you're making an impact if folks want to see you again, right? Because time is precious. Anything else? Any questions so far before we move on to evaluation? We can always come back if anything pops up. Carolyn, great question. How can we involve our overly busy local pharmacists to help promote the initiatives of our AD services? Ooh, outreach. That's interesting. It really depends on sort of set and setting, right? Like you're saying that they're overly busy. It may be something as simple as laminating a flyer and asking their permission to leave it somewhere where other clinicians may see it. Are you asking about whether pharmacists would be open to, like, would they be promoting it from pharmacists to other pharmacists? Give us a little context.
I think more, we have kind of a small community, so leaning on their expertise and their good name in partnering with our providers. Because I have a grant that addresses specifically controlled substances. And so, hearing from our local subject matter experts, the pharmacists, I think would have a big impact. Like what are we seeing in our local trends, and their voice being able to relate that to our local providers and things. I don't know,
So,
just utilizing that profession, I think would be really helpful in this situation.
we're going to have
I can speak to that a little. Go ahead. No, Bevan, you first.
I was going to say we're having a presentation this afternoon too about like how to engage local pharmacy, folks, pharmacists
Right.
and other people who work there. So that might be helpful. And then the other thing I was going to say briefly is just trying to schedule some sort of like staff kind of all meeting to just like, instead of a one-to-one or a fly-by-night kind of, I'm going to drop this off, might be a way to go. Amanda, what do you think?
Yeah, I was going to say when we were really heavily involved with our opioid topic, we detailed community pharmacists. So we would go out and specifically talk to them about naloxone prescribing, naloxone acceptance. Most pharmacists, surprisingly, at least in our area, had never opened a box of naloxone before because they're required to dispense it unopened. And so they were feeling like they actually couldn't counsel well on naloxone because they had never held naloxone in their hands before. And so just getting them some demo naloxone in their hands, talking to them about it, and then spreading that wider message of we're really trying to focus on the clinicians in our community in primary care who are doing these other aspects of opioid management. I think that built a really nice bridge. So we weren't just asking the pharmacist to do something, we were partnering with them to participate as a, participant of academic detailing first, and then saying, as you're speaking with clinicians, would you be, open to talking about how helpful this service was? So, and we offer CME credits as part of our service. And so pharmacists need CME too. And so we had good participation that way.
That's really great. I love the idea of
Thank you.
demos. Yeah. Carolyn, go right ahead. Did you want to share anything else? Good. Okay. All right. If any more questions come up in this realm, please drop them in. We're going to transition to evaluation. Amanda, over to you.
Thank you. As I mentioned before, we do not need more research on academic detailing. I mean, there might be areas where we do, but certainly just the classic one-to-one detailer clinician encounter, we don't need more research on it. However, evaluation is important. It's really important to identify key outcomes that you are going to use for your particular service or program. And establishing these outcomes are going to help you track progress and identify areas for improvement. it's also really important to be able to respond to whatever your funders are asking you to do. So again, we don't need research, but we do need evaluation. And this is something that you really want to think about early in the process. If you wait until you're already working on delivering your service, you may miss an opportunity as far as your evaluation goes. So as you're planning your whole service, or if you're realizing now, gosh, I should have been thinking about this all along, it's never too late. It's a good time to get started and really think, how can I have the most robust evaluation plan I can, given my budget? That I probably don't have access to statisticians or data people. Maybe you do, maybe you don't. I certainly didn't. So what could we do with the knowledge that we had in our own program or service?
And we're going to talk about it. We're going to talk about the ways you can measure so many different things that you don't need a ton of money to be able to measure. So Amanda, you'll
Yes.
lead us through this.
Yes. So the easiest things and some of the more important things, if you are the program leader, is to think about fidelity to the intervention of academic detailing. These are your detailer reported measures. How many visits did you do? How long did they take? Were you successful in delivering your key messages? Did you deliver some? Did you deliver all? What challenges did you have? What resources were you successful in sharing? What actions? What happened during the visit? What was the level of engagement in the clinician? There's probably many more of these types of measures, but these are some good ones to start capturing so that you can not only report out to your funders, but also have that continuous quality improvement for your own service and your own detailer community. And even if it's just you, if you're a party of one, it's still really helpful to track these metrics. So you can say, well, what's my average visit? Maybe it might be something like how many attempts did I make before I made contact with this clinician and got a visit scheduled? Anything that can help you manage the logistics of your program is a good idea to collect. Very cheap to do. You don't need a lot of budget to collect these metrics.
And it can again point towards future funding. Let's say that you have an initiative to talk about co-prescribing naloxone. And of the 12 people you saw, 9 of them wanted to discuss medications for opioid use disorder. You can then go back and say a huge percentage of the people, which again, if it's only 12, you can still build that up. It's all about how you showcase the data and say a huge number of these clinicians, the majority of them want more, right? So then you can ask for more training. What about clinician measures, Amanda?
This is like the sweet spot on a low budget is the clinician measures. Um, we ask our clinicians immediately after a visit to fill out a little survey. How satisfied were you with our session and all that kind of stuff? And then 3 to 6 months after the visit, we send a follow-up survey that says, compared to, before the session, are you now more likely to? And we list our key messages and we have them rate, yes, I'm more likely to do X, Y, or Z. And that does two things. It reinforces the key messages again, because we want to continue to send the same message over and over and over again. And it also provides us a little data, which statistically admittedly is gamed because nobody says that they're less likely to do something later. So it makes us look really good. But again, it also does that double role of reinforcing those key messages and pretty easy to collect. I will say the response is very good to our immediate post survey. Our response drops off dramatically in that 3 to 6 months after later survey. So we do lose a lot of people, but even then it's really important. And in our program, right in our deliverables, we're funded by the Vermont Department of Health. It will say that we have to show that 75% of the participants who answer the survey say that they are committed to behavior change, for example. So we have certain questions that we have to report back to our funders. And again, on a low budget, we do this in REDCap with email. It's very low budget and it works great. On the
Yeah.
right-hand side, this is where things get more expensive. So this really depends on your access to data, your ability to analyze data, and what your budget is. So most folks, if they're doing any kind of medication related topic, want to know that there's at least prescribing data changes. Our program has always struggled with this because we're a statewide service. So there's lots of different electronic health records. We don't have a way to aggregate the data easily. We don't have the money to budget for analysts. So if, if you're in a program like the VA and you have full access to data, this might be a lot easier for you. You can also look at things like referrals, completed screenings, connections to services, patient-reported measures. Again, some of these, depending on your service, will be easier or harder to do, more or less expensive. So if you're on a budget, you're definitely going to want to do the things on the left, and you absolutely should strive to do the things in the middle and do what you can on the things to the right, unless your funder specifically says you have to, in which case I would have a conversation with them about how to make that feasible.
Yeah, give me more money if that's what you want. And again, some funders won't even know what to look for on this. They've heard academic detailing is a new thing to them, but they don't even know what measures to look for. Rarely does a funder come in and say, I'm an expert on academic detailing and this is what you need to do. So being able to suggest these is really key. You also want to establish a tracking process. So after you define the types of visit data that you want to collect, think about how you're going to collect them. Are you going to use a management platform like Amanda just used or talked about, REDCap, Salesforce? Those tend to have some degree of cost to them. You're going to use a Google Doc, which is free and it's live and everyone on your team can pop in and type in it. Are you going to do clinician pre or post survey data? And how are you going to do it? Are you going to use a tablet and say, please do this, 4-question Survey Monkey. Survey Monkey is free. Paper forms have mixed results. Sometimes, I've heard from Amanda herself that a paper form, it's right in front of them. They're going to do it and give it right back to you. Asking them via email to follow up and fill out a survey. I'm going to be asking you guys to do this about this event in 2 days. And I already know the response rate's going to be low, right? Because nobody loves a survey unless there's like a chance to win something or you're just a kind person who has a lot of time. So again, consider, hey, this might be like more, resource heavy to print out a ton of forms and then have somebody go in and translate what's being written into a database, but we might get more responses. So you're weighing a bunch of different things here. All right, we're throwing a lot at you. Let's apply what we've learned so far. We're going to pop you into breakout so you can have a breather from us. So we're going to give you an evaluation case study. Your AD program is aiming to encourage clinicians to address weight and lifestyle management, bringing this back to stigma too, right, from the earlier presentation today, amongst patients with diabetes. How will you know that your program has been successful? What diabetes specific outcomes will you measure? And do not worry, those 3 purple boxes we just went over a couple slides ago, I'm going to dump all that into the chat so that you will have that good stuff in your breakout. So hopefully you can all see that. It should show up in your chat when you're in your individual breakouts. You want to be thinking about these and think about what the outcomes would look like. So you can give examples. Patients report going to a nutritionist, something like that. So walk through this in your group. We're going to give you plenty of time. We're going to give you 20 minutes, maybe between 15 and 20, but just a little more time than we gave you this morning. Any questions, please throw them out on mute. Otherwise, I am going to break you into some groups. All right, it looks like we have everybody back. So pop on over to the chat box and tell us any one of these that you discussed. In what ways did you determine with your partners in your breakout groups that you would know if your AD for Diabetes program was successful? Feel free also to just chat. Charles, you're unmuted. What did you guys talk about?
We talked about a lot of things. I was looking, well, one thing we talked about early on was just sort of the length of a visit. And Nicole was saying, I think hers run about 45 minutes. Ours tend to run about an hour.
Oh, wow. Okay. Okay. So that would make you feel like if you had a longer visit, that was, you were more successful. What else? What else did folks talk about? Please pop it in the chat or unmute yourself. The challenge of accessing patients to collect information directly from them. Yes, that's why that measure is all the way to the right on the spectrum of easiest to most difficult. Yes, that is challenging. You could try to administer surveys. You would, of course, need to get permissions from whatever, clinic, hospital setting that you're in. Anyone else have anything to share? Carolyn, you're unmuted. What did y'all talk about?
I was just like trying to type it in the chat. So we talked about, first of all, following up with the physician and seeing if they've made any changes, impactful changes in their practice. And then following up, doing patient follow-up surveys to see if they have implemented some of the things that the provider asked them to do, whether it was a referral to a nutritionist or an endocrinologist. And then are they seeing any difference in how they feel or in their blood sugars or in their A1C, their follow-up labs at 3 months or something like that? Are they seeing any changes in the way that they perceive their health?
Awesome. Love that. Yahaira, would you like to share a little bit more? I'd love to unmute you if you have a minute to talk a little bit more about some of these referrals that you listed.
Yeah, so the DPP, so the Diabetes Prevention Program, if your A1C is a little bit elevated, or if you're already diagnosed with diabetes, for the DSME, the Diabetes Self-Management Education programs are out there, and a lot of them are covered by insurance, but people are unaware of them. So working within the diabetes space, we see it a lot to where referrals sent out, but the loop is not closed. So maybe the AD helps, making an emphasis to the provider of the importance of actually enrolling in these programs and closing the referral loop to having the patient actually complete them.
I love this. This is wonderful. Exactly the kind of thing. And there's other great stuff in the chat, detailing more than one person in a session, looking at that and what each person thought. Meeting with the result of meeting with a detailer clinician survey questions. Will you change your practice? Maybe a little more specific. Anybody else have anything that wasn't included on this? Narissa, anything you want to share about some outcomes that would, because I know that your group actually did do a diabetes initiative a while back. So anything there?
Sure. In terms of this group, I was with Julia. So she talked about that. With Illinois Advance, we had done some of the things you guys talked about with clinician measures. So we do both survey, because our group is all pharmacists, primarily focusing on pharmacotherapy measures. So change in prescribing of SGLT2s or GLP-1s.
Awesome. This is all good stuff. You guys know what to do. All right. So we're going to talk a little bit
I'll
about.
add that
Go ahead,
I'll just
please.
jump in that we wanted to do that breakout because evaluation is one of the biggest challenges programs have, particularly on a budget. So I would just wrap up by saying it's really good idea to make your wish list of all the metrics you wish you could collect, and then think about what's feasible to collect from there.
Love that. I'm gonna put that in the chat. Make a wish list, go big. And again, conversations with your funding source are key. All right, let's talk a little bit about developing key messages. Amanda, over to you to walk us through this.
Yes, key messages. I love key message development. We could spend hours talking about it. It is really important to get your key messages right by being clear and compelling. Again, we already mentioned talking about strong action verbs, really making sure that clinicians don't think it's a secret. Like, what do we want them to do? We want them to change their behavior. How do we want them to do it? We've got to give them the guidance of what it is we want them to do. So key messages should be concise, clear, actionable, and supported by the evidence. And Bevan's put up a nice example here.
Yep. Initiate a conversation about substance use with supportive, non-stigmatizing language. There's so many other great examples, and we actually have a brand new series called Skills Lab for this year, where we teach you how to do something with concrete, tangible skill development in less than an hour. And our first one is designing key messages and detailing aids. So I'm going to drop that link right in the chat. You can go check out that Skills Lab. And there's also another Skills Lab on how to recruit team members. We'll talk about that in a minute. Creating or adapting materials. We love our little infographics. They make dense material a little more attractive. This is a little bit of an older one. I'm sure we could have made it more appealing. It is the link between oral health and chronic disease. It was a detailing initiative in Colorado for dentists. I would have loved to see a little tooth on here, maybe with a face. So, you know, there's always room for improvement. But we have a lot of really awesome links here that I'm dropping in the chat. We have a how-to guide on how to build a detailing aid. We have a how-to guide on how to field test your key messages for low or no budget. We have a 4-page editable detailing aid template, and we have a guide on making compelling visuals. You can check that out. Amanda, I know you wanted to say things about specifics to incorporate into a detailing aid.
Well, we know that all of your materials need to be rooted in the evidence. So it's really important that you do your homework in understanding clinical guidelines, key meta-analyses or review articles, key studies that people want to know. That's the stuff underneath. The materials themselves should look easily digestible and accessible, but it's really important that the program and the detailers know all of those important data elements that go into that detailing aid.
Yep, 100%. Now, let's say you're terrible at graphic design, which many of us are, and you can't afford to hire someone. Do not worry. There's Canva, there's Pictochart. Most of them have a free kind of entry level. You get a couple of these things for free and you pay like 12 bucks a month for the more fancy bells and whistles. You can also visit our library of materials and borrow from experts and other programs. Amanda, I know you wanted to share about that.
Well, first of all, I'll just tell you that I'm the poster child for Smart Art in Microsoft Word. That's the type of budget I'm dealing with. So, you know, I maybe have migrated to Canva more recently. But yeah, I just want to stress that you don't have to have graphic artists to be able to put together really nice materials and have them be effective. The materials don't replace the detailer. The materials support the detailer. So you don't have to get perfect here and get that in the way of good. Like, just do the best you can with materials if your budget is low. For us, it has been critical to develop partnerships and relationships with other academic detailing programs. The RX Files program in particular, Julia's program, like that has been so helpful to us over the years. The South Carolina program has been helpful to us. The VA has been helpful to us. So oftentimes we reach out to other programs. NARCAD can help broker these relationships, and we'll just say, hey, we're doing this topic. We saw that you have amazing materials. Could we adapt this one piece? And of course, we will give you credit for developing that. And that can save a ton of time and also really help you out in terms of developing really good materials. So don't be afraid to ask other programs if they're willing to help share.
100%. Amy asked a great question about how to make things accessible. It really depends on, you know, how you'd like to do that. There are free programs online as long as you only use them once or twice a day. I know this because I use it for our podcast where you can transcribe certain things so that they are, you know, ADA compliant for folks who are blind. I don't know if that's what you are discussing, Amy. And then also Narissa has some stuff in Design Express, Illustrator. I don't know if that's something you wanted to add at all there. Amy, am I getting at your question, or is there something else that you're thinking of? Oh, okay. Contrast checker to make sure things are easy to see for visually impaired folks. Gotcha, gotcha. All right, we're going to transition to the last chunk here. Pop into the chat box. What are 2 adjectives that you think make the quintessential detailer? This is tricky if you are a detailer because you're like, me, also me, maybe. I don't know. How would you describe yourselves? And while you're thinking about that, we're about to talk about recruitment. So if folks have questions or stories to share about how to recruit folks, that would be fantastic. But pop two adjectives in. Julia says prepared and personable, which are two things I would use to describe Julia. Listener, enthusiastic, adaptable, and engaging, 100%. What else do we have here as we think about the kinds of people that we want to be hiring? As you're popping that in, I'll talk to you a little bit about how we support folks in our field in hiring. First of all, we do have a skills lab for that and a how-to guide that I'm going to drop into the chat box momentarily. But you want to consider their background in healthcare, public health, or education, or some sort of adjacent field. Sometimes sales really helps. Communication skills, they have to be incredible communicators. You can be an absolute expert in your clinical field, but if you cannot communicate effectively, you will get nowhere. And so that's something really key if you're thinking of expanding your team. To remember, you don't necessarily need someone with a PhD. You need someone who can talk to people. It would be nice if you had both. But also thinking about finances, you may want to think about hiring graduate students to do your detailing. These are folks with more flexible schedules and who it would be more cost effective for you to hire. You want the time, resources, and dedication and passion able to be applied to the project as well. So making sure that folks are excited to become detailers and that they have the time and space to do things like travel, show up at odd hours at clinics, etc. And you'll see the skills lab and the how-to guide about recruitment right there in the chat box. All right, last but not least, and these are our last slides, you want to train folks. Amanda, I'm going to throw this one to you.
Sure. Again, the lens of low budget here. While we would love to have big training retreats with food and speakers and all of that, the reality is you can train your detailers really, really well on a low budget. It's very important that you have a real internal consistency to how you train detailers. So this could be having folks do journal club, reading the original article from Jerry Avorn on academic detailing. I love starting with that so that people have a history of what's happening. And then we fold in some other articles, doing shadowing so that you bring new detailers in a visit with you. They can see it live, they see the community, really talking about the communication techniques of academic detailing. And all of this happens before you ever talk about what clinical topic you want to do.
100%, just to set the foundation. And of course, this is a little plug for us. We have a new course coming up in July. It's all virtual. It's 3 days in a row, afternoons only on a Tuesday, Wednesday, Thursday. I'm going to drop the link in the chat if you have anybody who wants to participate in our training. If you are on a budget and cannot afford to do a full training session with a group like us, come email me and I will send you some shortcuts that will get you as close to where you need to be as possible for next to nothing. Last but not least, this is our last slide. We want to talk about the critical importance, no matter what you have in your pocket, of building community. You want to convene your detailers often for consistent delivery and team building. And you also want to make sure that you can talk out your biases, your approaches, your nuances. And as Amanda said, just like you want to have consistency with how you train folks, you want to have consistency with how those folks go out into the field. Yes, every human being will be different and have different communication approaches, but you want to make sure the ways that key messages are delivered are very consistent. And Amanda's going to talk a little bit about upskilling.
Sure, I didn't coin this term. I think maybe Frank May did.
Oh, okay.
I think maybe Frank May. But upskilling is the process of getting your team ready to go with the next topic. And usually it involves some pre-reading and conversations together. You might involve specialists or patients or primary care clinicians as well to come talk about your topic and your program. But the idea is that before everybody hits the field, everybody on your team knows exactly what they're there to do, why they are there to do it, the nuances of the topic, and so that they feel really confident and prepared to have a great conversation with a clinician.
It's like a mini boot camp for your next campaign is what I think of it as in a way. You also want to convene folks so they can share ideas and overcome challenges together. If you're going it alone or you have a very small team, maybe you work with one other person, talk to us. We host community check-ins and events regularly. Our next community check-in is in just a couple of weeks, and it's a lot of fun, and people come together and they just off gas and shake it off and talk about good visits, bad visits, challenges, whatever is relevant for them. So wrapping up, the best way to get started is simply to start. You can use our project planning inventory, which is in the chat. I know we dropped a lot of links here, but I'll make sure you get them all on our Summit Hub page. Start with a timeline. Map out what you know, fill in the gaps as you go, and ask for help. We are here for you. So in the last couple minutes, I'm sorry, this was such a juicy, jam-packed session. Really appreciate your questions and feedback along the way. Are there any burning questions as we wrap up about how to do some of this work on a budget, or anything that you want to offer to the group in terms of ideas and things that you've done that have been helpful? Feel free to throw your hand up or pop it in the chat. All right. Amanda, any closing thoughts as we wrap up?
So many thoughts. I think I'll just end by saying that, you know, our program started in 1999 and we're still here. We still have a low budget and we still feel like we're delivering a really important service to as many people as we can possibly reach. It requires some flexibility and some real thinking around what we can and can't accomplish. We would love to do more, but we're still out there, you know, living the dream. So it is possible, whether you have a low budget or whether your funding just got cut, to keep going and to still have a good time with it. We love doing it. That's why we're here.
Yes, and making sure you're still connected to that, and also be realistic with your leadership. If they have no idea what something costs and you need to tell them, like Narissa has said, hey, we're being pulled towards this prior auth queue right now, and I do not have time to be hitting the field as much as I used to. Communicate, get that empathy and community building going with leadership too, as much as is humanly possible. Let them know when you need help. Let them know, hey, I can't do 20 visits this month. I can only do 10 if I'm going to do it well. So making sure you take care of yourself is just as important as making sure you have the right evaluation parameters set to go. Please stay in touch. I know many of you personally, but if you're new, you can always reach out to me directly. My email is right there on the screen. I really look forward to hearing what you're going to do next. And for those of you who are brand new, welcome. This is a great community, and you'll have more of a chance to connect with them this afternoon and tomorrow.